Okay, we have time for questions, so if anybody has a question, come up to the mic. While we're waiting, I have a question for our panelists. It's kind of a general question. Given the increased complexity of healthcare systems and the fact that we know that there are glitches on the one hand, and the other is that we know the potential benefits of socio-technical systems approach, what do you think are some of the current barriers to the marriage of those two things?
Go. So current barriers, I think, for that, okay. Current barriers, I think, I'll probably never be invited back. I'm going to go ahead and say it. I think there's an arrogance on our part in healthcare that this is going to be solved by the same kinds of problem-solving skills that we've learned in medical school and through other domains that we've interfaced with, mental health, public health, business, and it's not. We're all very, very smart people, but we have to accept that we need the expertise of others to expand the understanding of the work that we do. Just as she was discussing the fact that the consultants in her study here, Casey, wanted to talk to another human at some point, right? In the last part about the genetics and getting the data and wanting to get that kind of feedback. And we need to open our doors. I've been working in the human factors community for almost 20 years now. I go to their meetings. There are 3,000 or 4,000 people that show. There's usually about 11 physicians. We're not there. And so that, and their conversation with us is, how do we get access? We don't know how to bring our expertise in. We are not welcome, because often the message they get is, only we understand medicine and we can solve it. I don't think Chick-fil-A went to the owner and said, how do we improve our productivity, maintain our, customer service levels? What do you think we should do? They went outside. They went to others who are expertise in that kind of work. And that's one of the, I think, the major barriers. There are people who are poised and interested, and there's a whole body of research in human factors related to our domain, but we don't tap into that. And it was nice meeting y'all, because I know you want to invite me back.
Thank you. Sir?
Fascinating. I'm an engineer, and I am not, my only experience with the medical profession has been as a client. And frankly, what I saw today horrifies me. We have no way back to the country doc. Carried everything, all his knowledge and all he did, in a suitcase. But the country doc operated to the way that most of us ran chemical plants, which is what my life has been all about. There were simple rules: yes, no, this, that. The more you complicate the system, the more you bring in error, the more you bring it impossible for people to develop yes, no, this is my job system. I love your presentation. But there you are, adding more complexity on top of more complexity, and you forget at the end of it, there is an individual that needs to make a simple yes, no, maybe decision, and can't get there because we are in absolute data overload. So I don't know how you solve that. But ultimately, your answer is that employee who has to make a decision and help that person without overloading that person with so much detail that the hell with it. And I'll tell the next person to make the decision. I don't know. I think that's helpful.
Since Aisha keeps handing me the microphone, so a couple of things. I'm assuming that was a third person you, and not you as in me personally. Me? No. So I don't think I created that system. I have uncovered what is the secret. Okay? Anyone who practices healthcare or who's been a patient in the healthcare system knows this is what we do. I feel very bad for my fourth-year medical students, the third-year medical students when they hit the floor, and the fourth years and the interns, because they are gobsmacked with shock at how complicated this thing is that they're doing. It was easy to read the book and take the test and do well. It's different to be productive and to do well while you're actually working in a system that is 24/7, 365 days a year with multiple inputs and data points, and there actually isn't always a yes, no, maybe. Often it's, let's see how this unfolds, because we're dealing with a biologic substrate. And the difference between the chemical engineering model that you're offering and the model that I'm describing here is that you can predict what chlorine gas is going to do when it hits a certain chemical, and you have very clear rules on how the chemistry is going to unfold. The biology for us is unpredictable. One person having diabetes mellitus is one person with diabetes mellitus. He or she is not the same as the patient who has diabetes and coronary artery disease, and they also have peripheral vascular disease and schizophrenia. I don't know how their problems are going to unfold because there are a number of variables that affect my ability to approach each of those disease states. And the way that the substrate wants to respond to that, the genetics behind that, I'm often blinded to. So that the ability to cone down to that is taken by our substrate. Right? The biology does what the biology wants to do. And one of the interesting things about Trist's work related to the coal mining is that they spoke very specifically about the nature of the coal, how dense it was, whether the coal was in water, what other things were adulterating it, how that impacted the ability of the enterprise to actually work and function. If I replace coal with a patient, it's the exact same thing.
Okay.
And nice meeting you, because they won't invite me back.
Okay. We have another
Very
question.
quick comment.
Okay.
So the complexity is there, and it is getting there more and more as technologies are built. So actually, human factors is exactly trying, the science of human factors is exactly trying to do, as an engineer, what we are suggesting to do. We are trying to design systems so data reduction is the goal rather than data overload. Key information, so because we know as human factors people that humans have limitations. Perhaps some people think they don't, but let's think that most of us have limitations and strengths. How can we use and design technology to support those strengths and mitigate the weaknesses? So it is exactly what HF people are trying to do. The problem I see is, which is the answer to the first question, there is not an infrastructure in any of the hospitals. I mean, there are HF still, human factors still seems to be like researchy and luxury rather than we need to be on the table when EPIC is being purchased. No, I hear about it after. We need to be on the table when different brands of technologies are being provided here. Are we on the table? No, we are not. So we need to change that mindset and infrastructure if we want to manage complexity. I would use the word manage complexity rather than reducing, because it will be very hard to constantly reduce complexity when all technology is produced.
Okay. We have 3 more people who have questions, so let's try and keep our answers succinct so that we can make sure everybody gets to enter into the discussion. I think you're next.
So my question is for all the panelists. This is basically going back to finding that human engineering. And so it's definitely, you can see that there is a need for incorporating that in, let's say, in this community of care and engineering partnering together. But at times it's not quite possible to have like that expertise, maybe because you have some funding constraints in your research project or things like that. So what are your short tidbits on where to look for resources on gathering some more formal insight on this topic of human and systems engineering for this community?
So are you asking how you can do yourself versus
At least
finding the people who are experts?
Both in some way. So
Okay.
finding the people and also to get some concepts here
Okay.
before you talk with the experts.
So as you may have heard, we have now a Center for Healthcare Human Factors on the Armstrong Institute. Is there really funding behind that? No. But we bring all soft money, and we have to, and we are 16 people with different types of expertise. And we are not that people come and talk with us. If we can, we will try to help you. In terms of basics, there are two ways. I also, for example, mentor clinicians who are serious about HF and who have gotten K grants, etc., as like some expertise on that. But it takes some, it is not like an over weekend reading. It takes some time to develop that expertise. Unfortunately, we don't have a formal human factors healthcare program here, but those are some of the approaches, and we can direct resources if you need more.
I'd also add that there's an area called human-computer interaction that I'm a big part of that community, and we also work in this space. And in the biomedical and health informatics program at the University of Washington, I taught a required course for all of our master's and PhD students in biomedical and health informatics. It was all about human-centered design and interaction. I could tell the first day of class that there would be like half of them, mostly clinicians, who were like, I don't want to be here, I don't know why I'm here, this is a joke. And fortunately, by the end of class, I think they were all very convinced that this was a really important skill set to have. So I would argue that we should be adding user-centered design, human-centered design, human factors, human-computer interaction into our curricula across the board so that we at least are aware of these kinds of problems and can connect to the people with the right expertise.
I just want to mention quickly that there is now a meeting on human factors in healthcare that's sponsored by the Human Factors Society. It's going to be in April in Boston this year. Okay.
The HF Human Factors Conference regular annual meeting in October, and then the one in healthcare is in
Spring.
But the one in October also has a huge healthcare sessions and healthcare, etc. So both have a lot of healthcare.
Okay, the next gentleman.
I'd like to go back to keeping it simple. The country doctor who was making his rounds with his bag in the 50s went to medical school before it was even known that DNA was the repository of genetic information. So you could keep it simple, yes, no, maybe in 1955 or 59. Now we know, as you were pointing out, that every person in this room is different. We have a different genomic and epigenetic sequence, right? So every time we take a pill, it is not the same for every single person. We just generalize. So with that in mind, I'd like to ask the panel's perspective on something that Sarah brought up in her talk about assistive robots. So advances in artificial intelligence and robotics, right, is going to help caregivers in assisted living facilities, assisted robots. So 15 or 20 years from now, would you be willing, talking about being able to accept technology, you know, the 75-year-old doesn't, right? Would you accept in the emergency room or in the hospital an assistive robot connected to the Internet of Things, be able to put 10,000 or 20,000 or 100,000 pieces of information together with that patient to help you make the final decision on what should be done? Or would you say, no, I don't need a robot?
Can I start with a comment that as a non-clinician, but I would say that robot is another form of clinical decision support, and so it would be a matter of knowing that it's too much information and data for one person to be able to interpret, and for the clinicians or the stakeholders to embrace this idea of getting guidance from the machine. So I think that there would be some assessment of what would be the uptake of something like that as well.
Well, are you asking me as the 75-year-old woman? Oh, it's a 75-year-old woman who's using this device as a patient or as a physician? Thanks. My only concern, this goes back to cognitive engineering in general. So when we talk about medical decision making, if you're telling me that you are going to provide me data points that I can access in order to supplement my cognitive decision making process, which is naturalistic decision making, Gary Klein's work, the kind of decisions that firefighters make in the real time. So contextual pieces would still be part of that. I have no problem with a repository. I have an issue with being wedded to that when there are other contextual pieces that have to factor in. Quick example, can the patient afford the best medication for them? Or do I give them the second best medication for them because that's what they can afford? That's the piece that gets lost in the automation, and we tend to anchor on that and assume that this algorithm is the only way we can go, when we know, based on medication shortages, specialist shortages, et cetera, that the decision making is never that clear cut.
And
A
just
robot would know that.
just to add that the patient and the caregiver need to be in that model as well.
One last question, so we have to honor Greg with asking the question. Okay?
Someone who does research in AI and product. I thought maybe just kind of as a closing comment, one of the things I was sitting back here thinking about is how would we identify success in this area? And it really kind of comes to the fact that when in one of the presentations, I can't remember if it was you or I showed, there was kind of here's the plan as it was, and here's the reality of what actually happens. And the fact is, what goes on in a hospital is shaped by the patients who come in and their biological response. It's shaped by the nurses and how they take care of patients and the doctors. There's this incredible empathy that sets in as soon as you have the system in operation. So we're never going to, the engineer in me would love to optimize the system and say we produce the optimal healthcare system, and it simply doesn't exist. So what is success? How would we say we are now successful?
So two big points on that. One, if you look at the definition of human factors, it talks about joint optimization of human well-being and technology. So it is our system. So we are talking about we need to perhaps design better technology, better work systems, but we also need to keep people working in the system happy. So that is one comment. Second comment is, how do we know we are successful? If you develop a technology, for example, I will do that, and if people adopt it, and if you try to take it away from them and they start fighting with you, so that means technology became a team member, real team member. That is one big answer to your question.
Well, I'd just also add that healthcare itself has to be improved, right? We can't stay at this level of medical errors being introduced by the humans and the technology as being the third cause of death. That's tragic, and it needs to stop. But there's also, I totally agree with Aisha, but we need to look at some official outcome kinds of data and see that the systems are working well and performing well and not creating additional problems themselves, which is unfortunately happening.
Okay, one more quick comment.
So I was just going to say, in the context of decision support, we have this problem of fatigue often, where people are just ignoring what you're presenting to the clinician. So I think one success would be if it's being as intended, and not just being ignored.
Okay. Thank you, and thank you to our panelists. It was a very invigorating session.